I'd like to thank the organizers of this conference for inviting me to speak on pregnancy and renal disease. My name is Jessica Tangren, and I am a nephrologist at Massachusetts General Hospital. Both my research and clinical interests are in women's health and kidney disease. And my only disclosure is that I do receive research funding for an unrelated project from AstraZeneca. So unfortunately, 30 minutes is too short to discuss the breadth of issues in obstetric nephrology, so I've focused this talk on three main topics. First, I will review how kidney function changes in pregnancy and how we define abnormal kidney function during gestation. Next, I will review an approach to the challenging clinical scenario of acute kidney injury during pregnancy, where fortunately we have some new tools. And then in the last part of the talk, I will review the management of chronic hypertension in pregnancy. So let's start with a case. So we have a 25-year-old woman who was admitted at 37 weeks of gestation. In the prior 24 hours, she has developed abdominal pain, and she thought this could be early labor, so she presented for evaluation. She had been eating and drinking poorly due to the pain. In triage, her blood pressure was elevated, and she had proteinuria on her dipstick urinalysis. And because of these findings and that she was at term, she was admitted to the labor and delivery floor. Fortunately, her fetal monitoring was reassuring, and because of her term dates, she underwent induction of labor. Her labs from admission returned with notable for a serum creatinine of 1.3. Fortunately, her induction went smoothly, and 24 hours later, she delivered a healthy baby girl. So in speaking to an audience of clinicians interested in nephrology, a creatinine of 1.3 probably doesn't get too many people excited. But is this normal for pregnancy? So pregnancy is associated with remarkable physiologic changes, including alterations in blood pressure, glomerular hemodynamics, and tubular function. Maternal vascular adaptation to pregnancy really begins very shortly after conception, around 6 weeks of gestation, when this low resistance placental circulation starts to develop. The net effect is that cardiac output increases, but the low resistance placental circulation results in a reduction of mean arterial blood pressure that reaches a nadir between 18 and 24 weeks of gestation. Although we don't completely understand all of the pathways that lead to these changes, it's probably some interplay of vasodilatory and vasoconstrictive hormones, such as relaxin, nitric oxide, and alteration in the renin-angiotensin-aldosterone system, which contribute to these systemic and hemodynamic renal adaptations. So in parallel with all of these changes, what do we see in the kidney? So a majority of our knowledge of renal circulatory adaptations in pregnancies are extrapolated from small animal models and from some invasive studies and very small numbers of pregnant women. However, a group in Canada recently published a population-based study from the province of Ontario, where they studied over 300,000 measurements of serum creatinine across gestation. And with this, they were able to generate gestational age-specific estimates of renal function at each stage of pregnancy and in the early postpartum period. And as you can see, serum creatinine declines, reaching its nadir over a similar time frame as blood pressure between 18 and 28 weeks of gestation. So given the dynamic changes in GFR across pregnancy, defining acute kidney injury can be challenging. And a quote-unquote normal creatinine can really reflect significant compromise in renal function in a pregnant woman. Standard definitions of AKI, including the Rifle criteria and the Aiken criteria, which you all may be familiar with, have never been validated in pregnant populations. However, in general, we use these criteria to diagnose AKI in this population. And there has been some recent studies in obstetric studies showing that having a high Rifle criteria class predicted mortality in obstetric patients in an intensive care unit. So this table has been extrapolated from that Canadian study that I showed earlier, which shows the ranges of the 50th to 95th percentile of creatinine values across gestational age from this cohort. And what I really use these as an approximate normal creatinine values at each stage of gestation. And really in thinking about values above the 95th percentile should prompt additional assessment if there's concern that there's underlying renal problems. So how common is AKI during pregnancy? So in general, over the last 3 decades, rates of AKI have decreased in both high and low income countries. Studies from Italy show that the rates of AKI have gone from 1 in 3,000 births to 1 in 18,000 births between the 1950s and 90s. In India, while the rates of AKI are still higher, they have improved significantly from as many as 15% of pregnancies in the 1980s to less than 2% of pregnancies in in contemporary times. The decrease in frequency in AKI in pregnancy may be attributable to reduction in sepsis associated with abortion practices and with childbirth, and improvements in the management of postpartum hemorrhage and placental abruption. There is emerging data, however, that there is an increasing rate of pregnancy-associated AKI in high-income countries. While the overall rates remain quite low, studies from both the US and Canada show increasing rates of obstetric AKI. Fortunately, most of these cases are mild and reversible, and we really don't understand the long-term outcomes of this in women with AKI. The differing trends between high versus middle and low income countries may be explained in part by the trends towards older maternal age in high income countries and improved obstetric care in middle and low income countries. So let's return to our case. So fortunately, we've recognized that despite a creatinine of 1.3, this patient has quite significant renal dysfunction. Additional lab workup is notable for anemia, thrombocytopenia, and a high LDH and AST. So how do we approach the differential diagnosis of AKI in pregnancy? The clinical approach to AKI in pregnancy is similar to the approaches in non-pregnant adults. Although any form of AKI that affects adults in the general population can also affect a pregnant patient, several etiologies are more common in pregnancy. Really, the importance of making the correct diagnosis is critical because the management strategies differ. In the case of preeclampsia or HELLP syndrome, the definitive treatment is delivery of the placenta, which results in improvement in the symptoms, and kidney injury should recover. However, delivery does not treat conditions like TTP or HUS or other primary renal syndromes, in which case really therapy should be targeted at the underlying disease. The time of gestation at which AKI occurs during pregnancy can be helpful in determining the cause. AKI in the first trimester is frequently caused by hemodynamic injury, which we can see in the face of sepsis related to abortion practices, or extreme forms of hypovolemia that can develop from severe hyperemesis. The vast majority of AKI, however, occurs in the second and third trimester. And the most common causes are related to hypertensive complications of pregnancy, like preeclampsia and the HELLP syndrome, thrombotic microangiopathies, or atypical HUS or other TMAs of pregnancy. As I mentioned earlier, really the greatest challenge in evaluating AKI in pregnancies is differentiating between diagnoses with overlapping features such as preeclampsia and the HELLP syndrome versus conditions like TTP and HUS. And in the next upcoming slides, I'll review some of the distinguishing features between these conditions. So first, let's talk a little bit about pregnancy-specific causes of AKI. So preeclampsia being the most common. So preeclampsia is a multi-system progressive disorder of pregnancy characterized by new onset hypertension and proteinuria or significant end organ dysfunction, which can develop without proteinuria, always in the second half of pregnancy or after 20 weeks of gestation. This disorder is caused by placental and maternal vascular dysfunction and always resolves after delivery. The clinical diagnosis of preeclampsia relies on hypertension and, in most cases, proteinuria, which unfortunately are also the hallmarks of renal disease, which is why distinguishing it from de novo renal disease can be challenging. So an understanding of the underlying pathophysiology of preeclampsia can help guide our approach to distinguishing between primary renal disorders and preeclampsia. So placental dysfunction is the central lesion of preeclampsia. It's all a problem of the placenta. A host of risk factors likely contribute to poor placental development in early pregnancy. And as pregnancy progresses towards term, the resulting placental ischemia leads to release of circulating anti-angiogenic factors that mediate the end organ damage, including hypertension, proteinuria, and in severe cases, manifestations like liver dysfunction and cerebral edema. So soluble FLT1 is an anti-angiogenic factor released by the placenta that mediates the widespread endothelial dysfunction by binding to pro-angiogenic factors like VEGF and placental growth factor. There are a host of known risk factors for preeclampsia. Pre-existing renal disease, lupus, and chronic hypertension, all comorbidities that we encounter frequently as nephrologists, are among the most potent risk factors. So given what we know about the underlying pathophysiology of preeclampsia, it's not surprising that these conditions are associated with poor endothelial health. Because preeclampsia is a disorder of the placenta, in patients with worsening proteinuria or renal function in pregnancy, we can sometimes gain clues that this is placental-mediated disease by assessing placental function. Gross examination of the placenta on ultrasound can provide some diagnostic clues in really the extremes of pathology. However, even more useful is examination of uterine artery and umbilical artery Dopplers. So the uterine artery provides maternal arterial blood to the placenta and fetus, and the presence of a persistent diastolic notch and high resistive indices is a sign of uteroplacental vascular insufficiency. Similarly, reversal of diastolic blood flow in the umbilical artery, which carries blood from the baby to the placenta, is also a marker of severe placental pathology. So preeclampsia is really a clinical syndrome characterized by hypertension and proteinuria or end organ dysfunction, but we see that soluble FLT1, this anti-angiogenic factor, mediates this function. And I'm going to show you some basic, some studies coming up next about how we can now use soluble FLT1 and placental growth factor to make the diagnosis of preeclampsia in women at risk. So new discoveries in the lab really have meant that we have the ability to assess the degree of angiogenic imbalance in women. So this is a study from a landmark paper by Sharon Maynard and Ananth Karamanchi, which was published back in 2003, which showed that in women with severe preeclampsia, circulating levels of soluble FLT1 are elevated, and you can measure that in the blood from these women. In what I think is a really amazing example of translation from bench work to the bedside, only 16 years after the initial, actually even less, 13 years after the initial characterization of these novel biomarkers, a large trial was published using these biomarkers clinically to identify women with preeclampsia. So this is from the Prognosis study, which was published in the New England Journal of Medicine in 2016. And what they did is they recruited women with suspected preeclampsia, so any concern for the development of preeclampsia, from sites in Europe, Australia, Canada, and South America. And what they looked at is the ratio of soluble FLT1 to placental growth factor that predicted going on to develop preeclampsia within the next 2 weeks. And so what they found is that if you had a ratio of less than 38, you were at extremely low risk for going on to develop preeclampsia. And this was really a robust finding with a negative predictive value of greater than 99%. So currently, women who with suspected preeclampsia, especially those who are remote from term, will be admitted to the hospital for close monitoring. And using these new diagnostic tools, really we can identify women who are at low risk for truly having preeclampsia and who can be safely discharged from the hospital with close monitoring, freeing up resources for women who actually need those beds. And so this study led to the approval and use of these markers in many countries, including much of Europe and Canada, where they are currently being used clinically. Unfortunately, because this study did not include women in the US and over 90% of the study subjects were Caucasian, the US FDA did not feel that this was sufficient evidence for their approval. But fortunately, we have new data that came out earlier this year. And so in November of this year, a large US-based trial of women in the US was published, which included a diverse cohort of women from 18 US centers in both tertiary centers and community level hospitals, all of which had to have a level 3 neonatal ICU. And so what the investigators looked at was the ratio of soluble FLT1 to placental growth factor that predicted the development of severe preeclampsia necessitating delivery within the next 2 weeks. And so similar to the prognosis study in this US cohort, they identified that a ratio greater than 40, so almost the identical value, was strongly associated with the development of preeclampsia with severe features within the next 2 weeks. And as you can see, using angiogenic markers for diagnosis vastly improved upon our ability to predict which women were going on to develop preeclampsia, greater than any of the current diagnostic strategies that we use for evaluation of preeclampsia. So these are really powerful markers. And fortunately, last month or 2 months ago, the US FDA cleared the use of these biomarkers. And I suspect we will be seeing large hospital systems start to run these labs routinely in pregnant patients. And I'm really interested to see how our OB colleagues start to use them in the US. So for women who do develop preeclampsia, fortunately, AKI is an unusual complication affecting only about 1% of patients with preeclampsia. However, because preeclampsia is so common, AKI associated with preeclampsia still remains the most common cause of pregnancy-associated AKI in the developed world. Fortunately, I really think the place where we're going to see the use of these angiogenic markers is to help distinguish between preeclampsia or AKI from preeclampsia and the HELP syndrome from other conditions, including chronic hypertension, de novo chronic kidney disease, de novo lupus nephritis. And there have been studies previously for research purposes that have shown that angiogenic markers can help distinguish preeclampsia in all of these conditions. So while at present, if we diagnose preeclampsia, the only way to treat it is delivery of the fetus, we do have some tools to prevent the development of preeclampsia in high-risk women. So this is an important study published in the New England Journal of Medicine in 2017, the ASPRE study, which randomized women at high risk for preeclampsia to receive aspirin at a dose of 150. So this was done in Europe, so a little bit less than 2 baby aspirin versus placebo between 11 and 14 weeks of gestation until 36 weeks of gestation. So they took aspirin from the end of the first trimester up until near delivery. And the primary outcome was delivery with preeclampsia before 37 weeks of gestation. And in women who were in the aspirin arm had a reduced risk of developing preterm preeclampsia. And based on this study, I routinely recommend that my patients with kidney disease going into pregnancy take 2 baby aspirin starting around 12 weeks of gestation to prevent the development of, to reduce the risk of development of preeclampsia. So what are some other causes of AKI in pregnancy other than preeclampsia? So the primary renal thrombotic microangiopathies of TTP and HUS are really important causes of AKI in pregnancy. Clinically, We think about TTP when there's prominent CNS involvement and symptoms, and hemolytic uremic syndrome, or HUS, when there is really significant renal dysfunction as the primary manifestation of the syndrome, or if we see the development of this TMA in the postpartum period. So why are both of these conditions more common in pregnancy? Well, we know with TTP, pregnancy is associated with decreased levels of Adams TS13, and thus it appears that pregnancy can be a trigger for new onset or relapses of TTP. Pregnancy also is a potent trigger for atypical HUS. More than 2/3 of these obstetrical cases present in the immediate postpartum period. And what's likely is that these are women who have underlying predispositions and to complement dysregulation, and that bleeding or infection immediately postpartum triggers complement activation. Similar to non-pregnant populations, genetic defects in the complement regulatory proteins can be identified in about half the pregnant patients with pregnancy-associated HUS. And those who have diagnosed complement genetic mutations are more likely to have severe disease. A real high level of suspicion for HUS is needed to allow for early diagnosis and treatment, because misdiagnosis is unfortunately common. In a Spanish cohort of pregnancy-associated HUS, over 3/4 of the patients also met clinical criteria for preeclampsia. I think we'll have better ability to distinguish these once we more robustly use angiogenic markers to diagnose preeclampsia in these populations. We know that outcomes are better with shorter duration from diagnosis to treatment. And eculizumab, which is a complement blocker, has been studied in pregnancies in women with PNH, and there are case reports of its use in pregnancy-associated HUS, and with really a very favorable safety profile. So some other causes of AKI in pregnancy. So lupus nephritis and other glomerular diseases are common. Lupus predominantly affects women of childbearing age, and kidney disease develops in about 30% of women with lupus. So pregnancy-related immunologic and hormonal changes can result in flares or de novo lupus developing in pregnancy. And preeclampsia is a frequent complication of pregnancy in women with lupus, especially in women who have pre-existing lupus nephritis. Lupus flares can be clinically difficult to distinguish from preeclampsia because we see renal dysfunction and hypertension, which are also markers of preeclampsia. Helpful in distinguishing the condition is that the presence of low or low normal circulating complement levels, as well as our typical lupus serologic findings like anti-double-stranded DNA and an active urine sediment can really aid in the diagnosis of this condition. Finally, I just want to briefly touch upon a few points about hemodynamic kidney injury and renal cortical necrosis. So hemodynamic kidney injury is a common etiology of AKI. Usually we see this in the first trimester. When we see AKI late in pregnancy related to hemodynamic injury, it's really almost always the consequence of a catastrophic pregnancy complication, such as sepsis, obstetric hemorrhage, or an amniotic fluid embolism. Bilateral renal cortical necrosis is really the most extreme form of hemodynamic kidney injury and is seen more often in pregnancy than in non-pregnant populations. Fortunately, cortical necrosis is rare, and again, seen with these catastrophic pregnancy events. Pregnant women with severe renal ischemia are more likely to develop cortical necrosis, probably because you have this renal ischemia superimposed on the hypercoagulable state of late gestation, and that's what's postulated for this increased incidence of cortical necrosis in pregnancy. So can you do a kidney biopsy to make the diagnosis of AKI in pregnancy? So kidney biopsy is not contraindicated in pregnancy, but really should be considered only when the information is likely to change the treatment approach. In most cases of lupus and in certain causes of vasculitis, really serologies can assist in the diagnosis, and biopsy usually isn't necessary. However, in the case of de novo significant proteinuria in early pregnancy, or especially remote from term, a renal biopsy may be necessary to establish a diagnosis and to guide immunosuppressive therapy. And it's really considered safe as long as blood pressure is adequately controlled. A recent meta-analysis of kidney biopsies in pregnancy did show that there was a higher complication rate in pregnancy compared to non-pregnant biopsies. However, fortunately, most of these complications were minor, such as loin pain or macroscopic hematuria. And all significant complications occurred really after 26 weeks. Most experts will say that biopsying after 32 weeks is really contraindicated, as delivery is likely soon and it's unlikely to change management at that point. And I have never biopsied someone after 32 weeks. So back to our case. So unfortunately, this woman developed a postpartum hemorrhage and required an emergency hysterectomy, which was complicated by ongoing bleeding and shock. Ultimately, she was transferred to our institution, to the surgical intensive care unit, where she was immediately started on CVVH. This was a case where the working diagnosis was ischemic ATN, for which she obviously had reasons to develop, until really an astute senior nephrologist at our institution considered the diagnosis of atypical HUS, given that her anemia and thrombocytopenia seemed to persist after the resolution of her hemorrhagic shock. She actually received a few rounds of plasma exchange while an Adams TS13 was pending, and ultimately we convinced our hematology colleagues to give her eculizumab, and fortunately she was able to come off dialysis. So this was a case where we had not thought about atypical HUS, which really should always be in your working diagnosis of late gestational or postpartum AKI, especially where a microangiopathic hemolytic anemia picture predominates. So fortunately, our patient had a good outcome. But in the US, unfortunately, we continue to face a maternal morbidity crisis. Despite our extensive healthcare infrastructure and high-cost healthcare spending, women in the US die in pregnancy at almost 3 times the rate of women in other developed countries. So what is causing this rise? So obviously, we've made great strides in managing obstetric complications since the 1980s, and deaths attributable to obstetric hemorrhage, infection, and hypertensive disorders of pregnancy like preeclampsia have all gone down. However, deaths due to pre-existing cardiovascular disease or other chronic maternal medical conditions have gone up and are now a leading cause of maternal morbidity. So one of the major risk factors for pregnancy morbidity and mortality is pre-existing hypertension, which occurs in about 3% of pregnancies in the US and is only going to be increasing. Unfortunately, this condition disproportionately affects Black women and is associated with 3 to 5 times the risk of preeclampsia and 5 to 10 times increased risk of maternal death, heart disease, stroke, pulmonary edema, or acute kidney injury. And despite all of the morbidity associated with hypertension in pregnancy, really optimal treatment of blood pressure in pregnancy has been understudied. And up until 2019, the American College of Obstetrics and Gynecologists really only recommended pharmacotherapy for pregnant women with blood pressures greater than 160/110. And I can say, as a group of nephrologists, we all recognize that this number seems extraordinarily high. So the safety of lower blood pressure targets was recently studied in this multi-center RCT in women with either chronic or gestational hypertension. And so this was the life's work of the first 2 authors who have been champions in studying hypertension in pregnancy. And in what's very hard to do, RCTs in pregnancy, they randomized over 1,000 women to either a diastolic blood pressure of 85 or to a diastolic blood pressure of 100. The reason diastolic blood pressure was chosen is because there was theoretical concern that this is what is really determining placental perfusion, and the concern about lowering blood pressure in pregnancy was always the concern for placental hypoperfusion. And so what they identified is that there was no significant difference between any of the composite outcomes, with the primary outcome being pregnancy loss or small for gestational age baby between arms. And this really proving the point or reinforcing the point that tighter control of blood pressure in pregnancy is safe. Unfortunately, this study did not recruit in the US. And so really the American College of Obstetrics and Gynecologists did not feel there was significant evidence to change their blood pressure recommendations based on this study alone. But here the key point is tight control, reduce the risk for severe hypertension. And however, the primary outcomes for baby and mother were no different, reinforcing the safety of blood pressure control in pregnancy. Subsequently, in the last year, we have seen the CHAPS trial be published. So the CHAP trial was a US-based RCT where women were randomized to receive pharmacotherapy for blood pressure to target a blood pressure of less than 140/90 in the intervention arm versus 160/105 in the control arm. And again, we saw from this trial that there was no difference in fetal outcomes, and that it was really safe to lower blood pressure to a range of less than 140/90. And fortunately, this study has led to the recent adoption of lower blood pressure targets by ACOG and the Society for Maternal Fetal Medicine, who now recommend targeting blood pressure less than 140/90 as the threshold for pharmacotherapy. So there are a number of drug options for the management of hypertension in pregnancy, including labetalol and long-acting nifedipine. While you'll see first on the list by age is methyldopa. It really does have an extensive history of use and is still considered a first-line agent, but unfortunately has a pretty terrible side effect profile, and in my experience, rarely leads to good blood pressure reduction. I really stick to labetalol and nifedipine as my go-to agents first line in pregnancy. Although diuretics are often avoided in pregnancy because of the theoretical concern of intravascular volume contraction leading to preeclampsia, it really can be used in certain pregnant patients. Similarly to other beta blockers and calcium channel blockers have been used, but again, because we have less safety information on them, I really only use them in patients where safer alternatives like labetalol and long-acting nifedipine aren't tolerated. All forms of renin-angiotensin-aldosterone system inhibitors, including ACE inhibitors and angiotensin receptor antagonists, are contraindicated in pregnancy as they are associated with congenital malformations, especially with second trimester exposure. In conclusion, I hope in the last 30 minutes or so, I've been able to impart some knowledge on renal functional changes in pregnancy, hopefully giving you an approach to AKI in pregnancy, and reinforce the importance of the management of chronic hypertension in pregnancy with really new guidelines towards more aggressive treatment of blood pressure in pregnant patients. And here are a few of the clinical trials which I have published both within the past year that I've highlighted in my talk, and feel free to reach out if you have any questions.